Good morning and welcome to the Juliet Shield Symposium. It's a real pleasure for me to introduce the plenary speaker for this year's Juliet Shield Symposium. Dr. Shams Syed is the head of quality of care at the World Health Organization in Geneva. He oversees the policy, strategic, and technical aspects of healthcare quality in fragile, conflict-afflicted areas. Sorry, I was getting some feedback on the other line here. Shams leads several innovative initiatives at WHO, including having created and leading the WHO Global Learning Laboratory for Quality Universal Health Coverage. Dr. Syed received his medical degree from St. George's at the University of London and was in general practice in the UK for many years. He received postgraduate public health training at the University of Cambridge and trained in preventive medicine at Johns Hopkins University in Baltimore. Dr. Syed's board certified in preventive medicine and public health, and he's a fellow of the American College of Preventive Medicine. Recent scientific research has shown convincingly that individuals who wish to respond to suffering with more compassion can develop these skills. But one of our most pressing needs is to scale up compassion to the organizational and societal levels to create environments and systems in which compassion can flourish. In both his personal capacity and in his role as the head of quality of care at WHO, Dr. Syed has been a tireless advocate for promoting compassion in the context of healthcare and public health services. One of Shams' key innovations has been to situate compassion within the context of quality. Compassion is essential for quality healthcare. As the global movement towards quality universal health coverage gains momentum under Dr. Syed's leadership, so too has awareness of the fundamental importance of compassion. In fact, several countries have now incorporated compassion and compassionate care in their national health sector transformation plans and their quality of care plans. Without further ado, I'm really pleased to introduce to you my friend and colleague, Dr. Shams Syed. Shams, the floor is yours.
Thank you so much, David, for that kind introduction. And it's a real privilege to be with you and all colleagues within this symposium. I'm going to try to share some thoughts with you in the next half an hour or so. I will share some slides, and if I could just check whether you can see the slides now, David.
Sorry, Shams. Yes, we can see them. They look great. Yeah.
Wonderful. Thank you. Colleagues, today what I'd like to do is to share some thoughts, and building on what David mentioned, some thoughts on how compassion can and should be an engine for quality primary healthcare. Before I get into the substance of the discussion, I wanted us perhaps to start with a reflection. If you look at these two landscapes taken from above, they don't look very dissimilar. They look very similar, in fact. But in this world of ours, if we look at the data, the maternal mortality ratio in that landscape is 638. So 638 women lose their lives in childbirth per 100,000 live births. And in this landscape, life expectancy of a male is 63 years and a female is also 63 years. That's troubling. In the alternative landscape, the maternal mortality ratio is 5. And life expectancy for a male is approaching 82 and a female 85. Are we happy to live in such a world? Are we going to accept this as the status quo? Those are statistics. Each of those deaths occurs in a family, each of those deaths affect a community. What can we do about it? Taking it a little bit further, and this comes from the work back in 2018 of the Lancet Commission on High Quality Health Systems. This was a watershed moment. The estimates that were provided in that report indicate that 8.6 million deaths per year in 137 low and middle income countries are due to inadequate access to quality of care. But importantly, and it's a very simple pie chart, but it has profound meaning, of those 8.6 million, 3.6 million are people who didn't access the system. They did not have access to the system. But 5 million of those 8.6 million are people who sought care, but received poor quality care. So these estimates for the first time indicated that the issues related to quality were affecting mortality in a profound way. Flipping it around, the same publication highlighted that high quality health systems could prevent 2.5 million deaths from cardiovascular disease, 1 million newborn deaths, 900 deaths from tuberculosis, and half of all maternal deaths each year. Clearly, seriously urgent. So there's a significant body of knowledge on quality of care. I indicated some points from the Lancet Commission's work, but WHO, the World Bank, and OECD at the same time, in the same year, 2018, published a clear report indicating the centrality of quality issues for universal health coverage. And the US National Academies of Science at the same time also published an important publication, Crossing the Global Quality Chasm, building on earlier work that the Institute had done in the United States. On the publication of those three important documents, our Director General, Dr. Tedros, asked a simple question in a Lancet editorial. How could healthcare be anything other than high quality, he asked us. And he said these simple words, which I often refer back to. Quality is not a given. Quality is not a given. It takes vision, planning, investment, compassion, meticulous execution, and rigorous monitoring from the national level to the smallest, remotest clinic. And through these words, and words have power, compassion was introduced as something fundamentally important to the delivery of quality of care. Many of you will be very familiar with the different dimensions of quality health services. But just to remind us, quality healthcare focuses in on different dimensions: effectiveness, safety, people-centeredness, timely, equitable, integration, efficiency. These are all articulated, and I'll come back to this to be able to touch on the compassion linkages. But when it comes to quality of care, improving quality implies change. As you can see, quality is multidimensional, and quality is the product of individuals working with the right attitude in the right system. You can see where the compassion piece might come in here. Let's think through those different domains and think through the linkage with compassion. So when it comes to effectiveness, very simply put, accurate diagnosis and treatment, we know that there is a deficit, and in some countries, only 35% of patients get the correct diagnosis. Now, where does compassion fit into that? That point of care is a critical point of care that requires an interaction between somebody who's receiving care and somebody who's providing care. We know that compassion can enhance the diagnostic accuracy within that point of care. Safety, very simply put, a health facility designed to heal should not harm somebody traversing that health service. But around the world, nearly 14% of patients are harmed from the healthcare they receive during their hospital stay. And of course, this varies across the world, but this is a universal problem across the world. Compassion has a part to play in enhancing the safety of patients that are receiving care, both in health facilities, but importantly, also in the community. The third domain of quality, people-centeredness, this is a no-brainer. Making decisions about care that are tailored to the needs of the people and the preferences of the people, and the treatment is being provided with respect and compassion. So this is a very clear linkage. People-centeredness and the focus on people as opposed to diseases is critical. Compassion is at the heart of that. The other four domains, timeliness. So the fact that somebody needing immediate care is going to receive that immediate care. The fact that somebody who needs a referral for an urgent issue is going to be seen during the critical period of his or her condition. There's a compassion element that needs to be thought in that. The compassion that comes from understanding a fellow human being. Equity. Is it acceptable? And I refer back to our initial landscape, the two landscapes. The care that's being received, is it being received regardless of the gender, the race, the ethnicity, geographical location, or socioeconomic status? If we take a compassionate approach, that equity part becomes fundamentally important. Efficiency. Are we being able to run our services to minimize waste? Will we be able to design services that do not encourage unnecessary testing? Will antibiotics be prescribed only in the case of an infection that requires it? There's a case in compassion for that. Efficiency, knowing that if you spend on something that you're unable to spend on something else, that efficiency has a compassion lens. And integration, making sure that chronic diseases, for example, and medical care is coordinated across all the parts of the service and the system. A compassionate system would allow an elderly gentleman to be seen where he needs to be seen rather than where the system wants him to be seen. But where do we go with this? How do we ensure that we are focusing in on issues that I've touched on, but in a broader context? The declaration of Alma-Ata, I think many of you will know, and as time has progressed, we've revisited issues related to primary healthcare. And when we talk about primary healthcare, we really refer to the primary healthcare approach, a whole of society approach to health that focuses in on, of course, primary care and the delivery of services and taking a public health approach, but also focuses in on empowering people and communities and multi-sectoral policy and actions that cover the wider determinants of health. And at all times, being as close as feasible to people's everyday environment. The primary healthcare approach is something that is being taken forward by many countries across the world. Importantly, the primary healthcare approach has been developed further in most recently in an operational framework that has been released by WHO and UNICEF. As I was mentioning, the PHC approach has these three interdependent arms, but importantly, it's not just about rhetoric and talking about these concepts. The levers that you see in the middle are strategic levers and operational levers that can be taken forward by countries. One of those levers, systems for improving the quality of care. Systems at the local level, the subnational level, and national level to continuously assess and improve the quality of integrated services. But quality doesn't sit by itself. It's touched upon by all of the different levers. And if you look at those levers and think compassion, some interesting things start to emerge. Just taking an example, lever 6 talks about the primary healthcare workforce. We know the challenges that our health workers are facing wherever we are on the planet, the issues of burnout, the issues that are quite fundamental in the most challenging environments, but also in so-called privileged and high-income country settings. We know that there are challenges. The compassion aspect comes in and can change the environment in those situations. But if you take any of these levers, there is an opportunity to bring compassion into the discussion. And the results that we're looking for are, of course, improving access, utilization, and quality, but also the empowerment results related to people and communities. And importantly, because our health care will not change the health of the population, it's the wider determinants of health that will ultimately lead to the highest yield. Improving determinants of health is a key result from taking a primary healthcare approach. So what's the glue in all of this? Many of you have heard my dear friend David Addis speak about the three-pronged approach that we take to compassion. And we've liked in the recent past to refer to this as a compassion equation, which we believe is required at every level. And what is that? The compassion colleagues in the symposium, you are the experts. I'm humbly posing some points related to the linkages and, of course, the theme of dissemination within this symposium. But the awareness, the cognitive awareness of suffering, the empathy, the emotional resonance with the suffering, and the action, a commitment to alleviate suffering, for non-compassion experts in health services, this resonates and it makes sense. For those that are experts on compassion, of course, you will delve deeply into the subject. But we always highlight that this compassion equation is required at every level. So what do we mean by that? The point of care that we've mentioned a number of times, ensuring that that awareness, empathy, and action is taken forward at the point of care. In health workers, how health workers interact with each other, how health workers view self-compassion, critical. The health facility, how services are designed, how services are taken forward at a health facility level. What is the culture of the health facility? The district, particularly in low-income country settings, the importance of organizing services within the district is key. In some of the countries that we're working in, the district is the unit of organization, which requires strengthening, and it is a clear entry point for bringing a compassionate approach. And at the national level, David already alluded to this, there are glimpses of countries that are taking compassion as part of their overall health sector planning. And importantly, the global level. Can we imagine what the compassion equation would mean for dialogue related to global health? That is something that we perhaps are not strong enough on, and we can strengthen further in the times that come, particularly as we move into the mid-sustainable development goal landmark. So we have been exploring this with our colleagues at the focus area for compassion and ethics at the Task Force for Global Health, and with Our team at the Global Learning Laboratory, and particularly my colleague Oriane Bodson, we have been working closely on the Global Health Compassion Rounds. And why do we do that? We want to explore key issues with an openness to share, to challenge each other, and to spark. And we've been able to look at various aspects with the lens of compassion. A couple of points of emphasis. Palliative care, a clear entry for compassion at a very important part of life. In that exploration, it was very clear that for us, compassion has to be placed within the entirety of the life course, and particularly at the time when we enter into the twilight of our years. At the same time, another compassion round focused in on respectful maternal and newborn care to make sure and think through what the linkages are related to respectful maternal and newborn care, which is something that's been taken forward very extensively by our maternal and newborn child health colleagues, but thinking through what the intersections are and synergies are between compassion and respectful care. Again, thinking through what the triad of awareness, empathy, and action could mean for mothers at a very critical stage of their lives. But we've also explored issues that may not seem like they are directly related to compassion, like water, sanitation, and hygiene. The colleagues that we've explored this with are very clear. Compassion is at the heart of their efforts to drive clean water, sanitation, and hygiene in some of the most difficult parts of the world. It is an absolute disgrace that a large percentage of health facilities on this planet do not have adequate water, sanitation, and hygiene. Taking a compassionate approach to that would mean significant changes would be not just a wish, it would be a must. And we've touched on areas which are somewhat controversial. Compassion and faith, and the role of faith in global health. How, and particularly in this troubled world that we live in, can faith be brought in to the discussion to enhance quality of care, but taking that compassionate approach. And of course, we cannot do any of this without the necessary leadership. And when I mention leadership, it's certainly not about just the big leaders that often people look up at and think that they're the leaders, but the leadership that exists in every ward, in every facility, in every community. And often these leaders are unsung. How can we inject that work with compassion? More or less impossible to be able to discuss this without thinking about COVID-19. Our work within the COVID-19 Health Services Learning Hub at WHO has been able to take a spotlight and highlight the importance of compassion and the importance of compassion fueling the commitment and innovation to address threats like COVID-19, and thinking through individual level issues, health provider level issues, and again, leadership and organizational level issues. I'd urge you to take a look at this COVID-19 learning brief on the role of compassion in maintaining quality essential health services during the COVID-19 pandemic that was put together by the team at FACE. Turning back, and this is something that I often use when challenged by my colleagues, and many of you will know Avidis Donabedian as the godfather, I suppose, of quality of care. But he said these words, and they're very simple, but they're very important and they're very powerful. Ultimately, the secret of quality is love. If you have love, you can then work backward to monitor and improve the system. And this is hardcore science evaluation guru, quality of care guru, speaking about not just compassion, but speaking about love. So just to conclude, a few takeaways. It's very clear that the status quo for health services is unacceptable on this planet, and lives depend on action now to improve quality of care. There are clear linkages that are evident between compassion and multiple domains of quality of care within a PHC approach, and I hope I've been able to explain some of that. We really need to communicate this widely. In our efforts, we need to remember the context that we're working in, and just to challenge us not to be too complicated or complex in our thinking. Abstract concepts will mean little unless they are directly relevant and applicable for point of care realities. So we're talking about fragile settings, settings that are affected by conflict, settings with populations that are facing extreme challenges and are vulnerable. That in those settings, we need concrete compassion interventions. And we need to demonstrate results. We need to be able to show what is possible, and that needs a focus on measurement. And we need to build a virtuous cycle on compassion application. And that needs to occur, that learning and that virtuous cycle needs to occur within and between countries. And let's be quite open that the destination is unknown. That is scary, and it does create some tensions within our own thinking, but it's important to highlight that we need to build that practical learning on the role of compassion as an engine for quality primary healthcare. And just a thought to place for your consideration, do we need a Compassion Counts campaign? Coming back to these images, I'm not sure whether any of you will have thought about, okay, I wonder which country those images are from. One is Afghanistan and one is Switzerland. They look pretty similar to me, and the data points shouldn't be so dissimilar, as I've indicated at the beginning of this intervention. Let's remember that the Sustainable Development Goals are just around the corner. We often hear about the 17 goals, but we often don't hear about the 5 Ps: prosperity, people, planet, peace, and partnerships. I hope these Ps can be considered carefully as we head into mid-SDG analysis, but then also, and we should be thinking about this, particularly the expertise in this room that is a part of this symposium, the experts in the room should really be thinking, how do we bring something together for 2030 and beyond? We need to think about that very carefully. With those words, I'd really again like to thank the organizers for giving me this opportunity to be able to share some thoughts. I hope that's helpful in some way. And again, thank you. David, back to you.
Thank you very much, Shams. That was wonderful. We do have some questions coming in, and I hope you'll be able to field some of them. The first question came in is that, doesn't compassionate action require a deep understanding of culture and community features? We may have empathy, but in global health, we work in many different cultural settings. And how do we take that into account in order to act appropriately with compassion to address the needs of those who are suffering?
Excellent question, an incredibly important point. So for me, global health is meaningless unless we talk about local health. So global health, one could define it in many ways, and many have defined it in many ways, but the essence is to ensure that we're looking at local culture and context. And without that, global health is actually quite empty. It's particularly, in my mind, David, really important to consider local culture and context when it comes to compassion. That awareness that we need is awareness not just of suffering, but awareness of the local culture and context. And the empathy can only occur when there's an understanding of that local culture and context. And the action that will occur will also be absolutely determined by what the most effective intervention will be in that context. So thank you. The colleague who's asked this question couldn't emphasize that enough. And it's a great point.
Thank you. Another question has come in about your comment about compassion being important for all levels of care. Are there national guidelines for integrating compassion into primary care? And how is WHO assisting national governments to do this?
I was going to imagine that there'd be some difficult ones to be able to tackle here. It's a great question. We do not have current guidelines to advise governments on how to take compassion forward at the national level. We've taken, within the humble capacity that we have within the quality of care work, we've taken an exploratory approach, and we've wanted to shed a spotlight on issues related to compassion in the delivery of quality health services. We've also taken a careful look at national strategies that focus in on quality of care. And within those analyses, we've seen that there are a number of countries that are now moving towards embedding principles of compassion within their work. One of the things that we also recognize are that there are multiple entry points into the compassion work. So our colleagues at WHO that work on health workforce issues have been looking at health workforce competencies and also looking at labor market analysis and thinking through how compassion can be taken forward in health workforce issues. Others are also exploring in different ways. Now, what we would hope, and this is also an exploratory and I suppose a trajectory that we would hope for, is that countries as far as possible can share their experiences with other countries so that we can start to build some momentum around the importance. And when we engage with countries in this setting their national strategic direction on quality of care and services, we see a clear resonance with the issues related to compassion. And it takes time to develop that thinking further, but it's something that we should be thinking about very closely. On the primary healthcare side, just to highlight that the primary healthcare approach is based on social justice, it's based on ethical principles that are very akin to compassion issues. So there's another huge opportunity, particularly in the focus on community engagement and empowerment, to really think through compassion in a fundamental way. Thanks, David.
Thank you, Shams. And one thing I so admire about your work is that you are a bridge between compassion and these other groups. We don't hear of compassion and human rights in the same sentence, just as we don't hear often of compassion and business or compassion and even global health or public health, as you were mentioning, the water, sanitation, and hygiene. And yet compassion is what is the engine that drives all of that activity. So I think from my outside perspective, one of the key gifts that you've given to us in the global health community is this bridging and reframing compassion and helping people understand how compassion is central to the work that they're already doing and sort of helping them remember, yes, it's compassion that is why I'm here and why I'm doing this work. We had a question about what are the major obstacles that you see to really immerse compassion into the delivery of healthcare? You've laid out a really wonderful framework for us to think about this, and you've touched on it. But are there any other things you'd like to say about obstacles? And then maybe a second part is that what kind of research might be needed to overcome those obstacles?
Sure. Great question. Many obstacles, and you can start from if you look at any of the levels that I've mentioned, there are obstacles in all aspects related to how compassion can be brought in. But maybe there's a mother stream obstacle, which is related to actually an understanding of the principles around compassion and the added value, the so what of compassion, and also not considering compassion as an add-on. Return on investment is what people want to see. They want to see something that the service is going to get, something that the workers are going to get that they wouldn't have got unless compassion was brought in. Now, and that's why I do come back to this issue and often would refer to the fact that nothing succeeds like success. One needs to show and manifest how things succeed and not just keep it to a specific country. And that's where the WHO, with all its issues and faults, there's something that we can do on that front. We can share the experience of a country with other countries, and that's what catalyzes change. If we look, and coming back to these obstacles, if we look at each of those levels, the obstacles are somewhat different. So at the global level, now this is an open webinar. Well, I suppose we should be controversial. We should say what we think. At the global level, there are complexities, there are toxicities, there are many issues that need to be faced. And those issues need to be faced head on with compassion as an entry point. At the national level, we know each health service on this planet, if anybody can give me one health service that is not struggling with resources right now, would be good to know. Every health service is the richest of rich health services struggling right now for various reasons. Compassion is not high on the list of priorities, and that's an important recognition that we need to have in our efforts in disseminating our thinking on compassion. How do we get it there? How do we envisage that mind shift will occur? And again, demonstrating results, measuring results is going to be important. So I think David, you can see where I'm going with this, is that at each level, there are different types of obstacles, but many of those obstacles require upstream efforts on understanding concepts related to compassion and also the return on investment related to compassion. David.
Thank you, Shams, very much. That was very helpful. Here's another question about how, and it relates to what you just said about limited resources. How does compassion inform decision-making when addressing scarcity of materials and personnel? So in these very remote settings with limited resources, what's the added value of compassion when in those settings where resources might not be adequate to provide the care that the healthcare provider would want to provide?
Yes. Thank you to the colleague who's raised that point. This is where I come back to the context is key. And that one of my points is related to the importance of context. I think many of us have worked with colleagues in the most challenging environments. And in those challenging environments, what's consistent is a manifestation of compassion. So in fact, and could be counterintuitive, but actually, if you delve deeply into those challenging environments, those are actually the places that you will see the most compassion. And it's remarkable, absolutely remarkable. So I would maybe highlight that in fact, resources are of course key, and we will not shy away from that issue. But resourcefulness is equally important as resources. And that resourcefulness comes from compassion. So really understanding that we, as a health worker, and my definitions of health worker is slightly different to the usual. I'm not talking about doctors and nurses and allied health care workers. I'm talking about cleaners. I'm talking about estate managers. I'm talking about drivers. I'm talking about all of the colleagues that make a facility run in some of the most difficult places. It is very clear when compassion is percolating that facility or that district in the most challenging environment. So recently, having been in Afghanistan in a very difficult circumstance, colleagues are moving forward on improving or attempting to improve quality of care in the hospitals in Kabul in the most difficult circumstance. Where does that come from? It's a compassionate approach. They may not phrase it in that way, but that's where it's coming from.
Thanks, Shams. Boy, there's a lot of questions coming in. You've stimulated a lot of great thinking here. Do you have any examples you might provide on how healthcare organizations or other organizations, how they're promoting and growing compassionate leaders?
So definitely not an area of my expertise, David, but what I do recognize is the critical importance of leadership training and compassionate leadership training. We were very privileged to have a global health compassion rounds focusing in on this very subject. And here again, context counts. So leadership development in the United States is going to be very different to the leadership development that will be required in a country such as Malawi, for example. So there is a clear need for that leadership development to be injected with compassion. And the question is posed to those that are experts in leadership training for compassion, is that embedded within overall leadership? Or is there a necessity for compassionate leadership to be its own thing? Now, I don't know the answer to that question, but the experts need to think about that one. Again, it's feasibility of intervention, what's possible, and how we can bring that to make things better in those environments. That's going to find it quite difficult to have too many things at the same time. So very simply put, leadership is key, but whether there should be a sole focus or whether compassion should be embedded into leadership training and capacity building. And I shouldn't use the word training, because leadership, you don't train for leadership, you build capacity for leadership. That's also something that we should think about. And one final point is that all leadership capacity building should be action focused. So we know from the quality improvement world, and it's an applicable principle, is that theory doesn't work unless you practice and you continuously improve. So all of that has to be action focused right from the beginning. But of course, experts are sitting in the room in the symposium that will probably be able to take this apart a little bit.
Thank you, Shams. We've had one question from a remote listener asking about this issue of empathy, and it relates to what we perceive as almost an epidemic of burnout among clinicians, accentuated and even made worse by the COVID pandemic. Is empathy essential for compassion? And if we're trying to increase the capacity of people to feel the pain of others, doesn't that lead them to depression and being overwhelmed with that suffering? How can that be managed within the context of healthcare, which is really the context of physical and mental suffering?
Excellent question. And to be perfectly frank, I've struggled with this a lot. So I won't have a satisfactory answer, because having to work with colleagues across the world in some of the most difficult settings, you almost feel that you might be bringing burden and rather than ease by bringing in these issues. And that's a fair point that needs to be taken into consideration based on culture, context, locality. Having said that, focusing in on self-compassion and the compassion that exists between health workers can actually be almost like a vaccination for stress. So that's something that needs further exploration. Certainly wouldn't claim to be an expert on that field. But what I can say is that if we can capture what is happening on the ground and actually bring that to the table. So, okay, let's just examine a setting, think about bringing in issues related to compassion with a focus on empathy, because I do think that's a critical element of compassion. but then very carefully thinking through how that focus on empathy is affecting the trajectory of that individual. And being open to the possibility, as the questioner has put, that it may place some colleagues in distress and they will need support from the facility, the organization, and the health services within which they are providing services. And as you rightly said, David, we are at a really critical point in our health workforce. It is a difficult zone. And maybe we haven't been in this zone for some time. So we need to be very careful when we're bringing these issues into practice for health services anywhere on the planet. But I really thank the colleague for bringing this up.
Thank you, Shams. It's a question about global health is one of many global fields that have a global reach. What other fields do you see particular need for compassion? And if compassion were brought into some of these other systems, could they actually promote compassion within the healthcare system? So we're focusing on healthcare, but we work in rich networks of these many other fields. And what other fields, if those other fields were more compassionate, how could that influence compassionate healthcare?
Wow, that's a great point. And if I may, that's the power of the Sustainable Development Goals. Mm-hmm. The interdependence of the Sustainable Development Goals is one of its most powerful elements. And often, traditionally, health colleagues will gravitate towards Sustainable Development Goal 3 for obvious reasons. But we know that, for example, I was just using the example of maternal mortality ratios. So if we don't have effective transportation mechanisms, then the delay that will occur in a mother receiving care in a facility when it's required, you can do all you want on compassion and health services, but without those roads, you're in trouble. So to the colleague's point, we need to think about all of those aspects. And here, and not to get ahead of ourselves perhaps, but this is the role of head of state. It's not the role of Minister of Health, it's the role of the head of state. And compassionate policy making is actually something that we should be thinking about very carefully. What does that actually mean? And how is that going to affect the wider determinants of health? And this is again where the primary healthcare approach comes in. Those wider determinants of health is what has led to improvement in health parameters in countries across the world over the last century. It hasn't been healthcare that has led to those improved parameters. It is the entirety of the determinants of health that has led to those advances. Sometimes we forget that, and so it's really very good that we're being reminded of it. Compassion can be injected into all of those policy-making issues. Now, I'll be even more controversial. Peace is one of the P's in the Sustainable Development Goals. Without peace, any of this could be a little bit of a superficial discussion. So that's also something where we need to be thinking, how do we bring that in? But of course, we have our own sphere of influence, our own sphere of control, but we need to be aware of all these points that my colleague has brought into this discussion.
Thank you, Shams. And I would add that build the kind of bridges that you and your team have built with some of these other fields. It's very important. There are a couple of comments about love. The one about what is love according to Dr. Donabedian, and how does one promote it at the local and global levels? And then there was another question from another viewer asking about, could actually love be at the center of a healthcare system focused on profit, such as the one in the United States? What would maybe Dr. Donabedian have to say for our for-profit healthcare system in this country?
Right, we're stepping into US territory here. So
feel free to ignore that question if you'd like.
No, I mean, seriously, these are good questions. Now, for me, and again, as I've said, we're connectors. We don't claim to be experts on compassion or experts on love. But what we know is that there's something here that needs to be connected and integrated with other areas. What is love? That's millennia of thinking that's gone into that, right? So I'm very hesitant in making any point on that one. But what I would make is the point related to compassion and then the thinking expanding in an expansive way to love. And this is where issues related to humanity come in, is that the love of humanity, there's something there that we need to tap into. And how Avedis Donabedian was bringing this in, he was very intentional, and this was far ahead of anything. And this was, way back, that he's bringing in this thinking about love in the context of evaluating health services. You've got to be quite bold. And he did this, early. So the reason why I highlight that is just to be able to counter any issues related to hardcore evaluators thinking, what's compassion and love? This is just a little bit too soft for me. Somebody like Avedis Donabedian is at least mentioning it. So I've just got that to say, to be able to have that discussion with colleagues that might have a slightly different reaction to issues related to compassion and love in comparison to those that are on this call.
Thank you very much, Shams. I would ask if you have any questions or charges maybe, or things you'd like the participants in this symposium to keep in mind as we enter our deliberations on compassion, not only in healthcare, but in business and in other education and other fields. Are there things from your perspective that you would like us to keep in mind as we go into this symposium?
Thank you, David. I think one of the things to highlight is it's just wonderful that experts are coming around the table to explore these issues in depth. We need the expertise of those that are in the know in relationship to compassion. We need the information to be distilled in such a way that it can be applied. And we recognize with any field, there are going to be theoretical issues. There are going to be issues that need to be discussed, teased out, critiqued, and there's a long process in that. That's true for any field. But in terms of translational issues, we need something that can be then injected into, in my case, quality health services. But in others, it could be various other things. What I feel, and just having reviewed just some of the preparation documentation for the symposium, is the power of multiple entry points is something that seems to be very strong here. So if you can imagine compassion being applied to the field of engineering and bringing that in to a political discourse, and at the same time thinking through how healthcare is going to be taken forward related to compassion, these are all interlinkages that we need. So it takes effort to bring colleagues together in such a symposium, and it's wonderful that that's happening. Again, the big call is practical return on investment compassion packages, if for lack of a better word. Return on investment on compassion. How can we make the case on compassion so it's not seen as an add-on or a nice to have, but it's something that's a necessity? But we need to be able to articulate that to the most difficult counterpart. And so one last thing that I might say is, if I could urge colleagues when they're thinking through the body of work and the expertise, imagine yourself in front of a decision maker who is somebody that needs to be persuaded on the role of compassion. What would you say to that decision maker? And how would you be able to shift the mindset? A few points, David, but I'm really looking forward to seeing the synthesis of the product from this symposium.
Thank you so much, Shams. This has really been wonderful. I know that you're on the other side of the world. It's late at night there. You've had a lot of extensive travel. And I appreciate the extraordinary effort you've made to be so present to us and to bring your message with such clarity and power to us, and for entertaining some of these tough questions so well. So thanks so much. We're off to a tremendous start here at the Juliet Shields Symposium, and we really thank you for your participation and your superb comments to us today.
David, just a big thank you to you and all the colleagues that are organizing the symposium. It really is a phenomenal opportunity. And just to say a warm wishes, best of luck with the symposium, and look forward to hearing more about it once you've had the days of deliberation.
Great. Thank you so much, Shams. Hope you get a good night's sleep this evening. Yeah.
Thank you so much.
Take care.
Greetings from Brisbane. Bye-bye.
Okay. Bye-bye.